the last session for today's Congress, which is actually very, very important, talk about safety. Because as we know, for many new vaccines developed against COVID, many of the leading candidates are successful, are novel. That raised a lot of questions because usually a new vaccine will take 3, 5, even 10 years to be fully developed, licensed, even not so wholly word utilized. Now we are using that so rapidly. So there are a lot of concerns, including a reason for many people, they are reluctant to take our vaccine, even though that's very important. So we are very fortunate to have really the expert, I think, in this area about mRNA vaccine, Dr. Mariana Castells from Harvard Medical School, Brigham Hospital. She's MD and PhD. She is a hands-on clinician. I think that's why she has a lot of personal experience, also researcher and teacher. She is a professor for medicine at Harvard Medical School. She's also the director of Drug Hypersensitivity and Drug Desensitization Center, and also director for Mastocytosis Center, and work a lot on the allergy and clinical immunology. I think the reason we found her is she had the first paper at New England Journal of Medicine about mRNA safety. So it is our great honor to have Mariana here today. So next, I will invite Dr. Castells. Please share your great work.
Thank you very much. I'm delighted to be here. Thank you for the invitation to the 6th COVID-19 vaccine update. As mentioned, I think our great effort in this pandemic is to get everybody vaccinated. And there has been surfacing data, and which I will review today with you in terms of what has been happening since the beginning of the vaccination, and can we bring some granularity to what the potential side effects, acute reactions to the vaccines, and the more severe reactions such as anaphylaxis, because there is a growing body of people who says that they will not be vaccinated. And whether this attitude comes from, thinking that there's genetic material in the vaccines, or whether it comes from the known already hypersensitivity reactions, our efforts have to be geared towards providing the facts and providing the evidence. And so that's what I'm going to do for you today. Next slide, please. Next slide, please. Those are my disclosures, none of which conflict for what I will tell you today. Next slide, please. So yes, when the first two reactions, anaphylactic reactions to Pfizer occurred in December of 2020, we were puzzled because the vaccine had just started in the UK. And then two female healthcare workers who had food and drug allergies and who were carrying EpiPens had two anaphylactic reactions, one of them requiring hospitalization, but they did not die from it. And we were surprised to see that quick response. So Elizabeth Phillips from Vanderbilt University and I were asked by the New England Journal editor, Jeff Drazen, former editor Jeff Drazen, to weigh in on this. So our initial thoughts were that, with the vaccines, as with any other medication, we can have what we call IgE-mediated reactions, which is that somebody has seen a piece of the vaccine, some part of it, and has been sensitized, like penicillin sensitization or pollen or peanut. And those were kind of the reactions that were more kind of dangerous. Then there would be people who react to some of the ingredients without that sensitization. And then there would be people who would have what we call vasovagal, so they would be dizzy during the injection. So those were the acute reactions that we have known about vaccines. And then there are delayed reactions, and we'll review some of them, can be site reactions to the injection, can be some hives, can be fever, and can be also what we call serum sickness. So people who are sicker for a longer time, and the components of the vaccine have generated some immune response that then may deposit in the lymph nodes, in the kidney, in the skin, and that is a longer disease. It's called serum sickness type. So our job has been to just look at the clinical presentation of those reactions and try to, what we call the phenotypes of those reactions, try to understand what is underneath those reactions, and then try to see if we have biomarkers that can actually permit us to make an accurate diagnosis, and then to provide treatment initially, and then to see if the patients who, for example, react to the first one can be using the second one, and in addition to that, to see if patients who have some sort of allergies are actually safe to receive the vaccines. Next slide. So what we thought was unique to the Pfizer vaccine then happened with the Moderna vaccine. So this is shortly after, and this one happened here in the United States. And so a Boston physician developed a pretty severe allergic reaction, also thought to be anaphylactic, when he received the first Moderna vaccine. And this was also highly reported in the news, and that created a little bit of a panic in the general population. And that panic has actually continued up to now, where patients who have high allergies have actually been somehow reluctant, and even doctors have been reluctant to provide, some kind of risk to those patients. So I want to be a little bit more granular with that initial patient, since he became my patient, but I'm not sharing any data. Next slide, please. That is not public available. So this gentleman had actually no reactions to vaccines or other medication, but he had a high and severe allergic to seafood and shellfish. Initially, very early on at age 11, he had lobster and shrimp, and he had been seen in the emergency room and received epinephrine, which is a treatment for allergic and anaphylactic reactions. Later on at age 18, he had clams, and the same thing happened. And then more recently, he started to work at Mast General Hospital here in the United States. And again, seafood and shellfish contamination had induced those severe reactions. And more recently, when he just took a spoon from his wife, clam chowder, he actually had a pretty severe event. Next slide, please. So when he took his Moderna vaccine, within 2 to 3 minutes, and I think this is critically important because those reactions are very, very acute and occur immediately, so that a lot of people have been asking, could I go home after I receive my vaccine and then have an anaphylactic reaction? And the answer is no. The reactions happen immediately within minutes of being vaccinated. The patient waited 15 minutes, and then he started to present more severe symptoms. He had hypotension. He received epinephrine, and unfortunately, one of the markers and the biomarkers of anaphylaxis, which is called tryptase, was not drawn. He had some delayed symptoms, but no emergency room visits again, and he did not need an epinephrine. Next slide, please. So essentially, when we looked at his laboratory test, we saw that he had what we call specific IgE, which is a form, a protein that is in the blood, and that can be measured. Skin testing is also a way to do and evaluate allergies, like for pollen, for peanut, for other things, for other foods. And you see here that he had a pretty high, the number of normal is 0.35, and he had pretty high numbers for all the seafood and shellfish, the clam, the crab, the oyster, the lobster, the scallops, and the shrimp actually was very high. So we actually, and there is class 0, no allergies, class 6, the highest allergy, and he had some of those were class 6. So what we did with this gentleman is we measure his antibodies against COVID-19, and we saw that in the box, you see that his nucleocapsid antibodies were negative. So he had not been infected, despite the fact that he was working with patients and he was taking care of patients with COVID-19. But in fact, his what we call the COVID spike IgG and the COVID IgG RBD domain was really high, 7.8 and 8.10, greater than the negative control. So he was protected. And what we have been doing with this gentleman, we have actually been looking at his titers over time, and they have been slightly declining, but are still positive. And as we heard, besides this immunity by T cells, by B cells, we have immunity from T cells. So whether this gentleman requires, a second vaccine, we're still working on it. Next slide, please. So when we looked at the vaccines that we have available, we wanted to find if there is a common denominator that could potentially be in a way of patients who had allergies. And what we found is that polyethylene glycol, as you see in the first two ones, Pfizer and Moderna vaccines, is present. Polyethylene glycol is what's called the nanoparticles, the envelope of the virus. The next generation of vaccines, as you see here, others like the AstraZeneca, Janssen, Novavax, do have polysorbate, which is a little bit different. And so our questions were, are patients who may be sensitive to those at risk for the vaccine? Next slide, please. So essentially, my colleague Elizabeth Phillips has reported that in the general population, it is a rare allergy, but patients can actually react to polyethylene glycol and polysorbates. And some patients who have been exposed to chemotherapies, such as paclitaxel, who have been using products such as Miralax, may have been sensitized. And again, this is a rare occurrence to polyethylene glycol. And some patients may have been sensitized to both polyethylene glycol and polysorbate. And you see here in the left side that the skin testing was actually positive when you see the redness and the inflammation of the skin that indicates a positive allergy. Those patients have been identified as positive to polyethylene glycol and polysorbate. So again, those patients have reacted to compounds before being vaccinated that do contain that, could be potentially screened and then protected against those reactions. Next slide, please. And we have done, in conjunction with my colleagues, Dr. Blumenthal and Dr. Banerjee and Mast General Hospital and ourselves here at the Brigham, is we have now a skin test panel where we can actually check for polyethylene glycol, for polysorbate, and the polysorbate comes in several versions, polysorbate 80, polysorbate 20, and we have been able to actually assess if the patients who have reacted to the vaccine or patients who have reacted to other medications are at risk when receiving the mRNA vaccines. Next slide. So one of the things that I wanted to mention also is the diagnosis of anaphylaxis is important because we have to be attuned to what we call symptoms and certainty. The symptoms of anaphylaxis will include skin symptoms like hives or swelling associated with changes in blood pressure, changes in being dizzy, also gastrointestinal symptoms. So we have some level of certainty for anaphylaxis and the symptoms that associated with it. And as I'm mentioning, skin symptoms, cardiovascular symptoms, respiratory, gastrointestinal symptoms are actually paired with a laboratory test that's called tryptase. And once we have a tryptase elevation, we are under certainty, 100% certain that the patient had an anaphylactic reaction. And then so we have levels of certainty like level 1, 2, and 3. For 3 would be potentially possible and probable for level 2, and then a level of certainty 1 means that the patient did indeed had an anaphylactic event. So why is that important? For a patient who had a level of 1 certainty, the next vaccination will need to be carefully weighted. For patients who have levels 2 and 3, potentially pre-medication could be used and they could receive a second vaccination under pre-medication. Next slide, please. So my friend, the mast cell is that the one that is reactive when patients have anaphylactic events. As you see here in the left side, that mast cells have an amount of receptors in the surface that are important. And as I was mentioning to you before, the IgE receptor is the receptor that we have seen is active in patients who have a penicillin allergy and other allergies. But what I also want to mention is that mast cells do have other receptors receptors that we have recently been aware of, MRGPRX2 in the bottom, and those receptors could be more sensitive to what we call the solvents. So patients can actually react through a compound that induces an IgE-mediated reaction, but they can also react to the solvent through a different receptor. Those two types of reactions can be determined by, like we were saying, by skin testing to the pure product, and that's important, and I will emphasize that at the end of my talk. And then the most important thing is to have a biomarker of those reactions, which is called the tryptase level. So in case of an activation through IgE or through a non-IgE receptor, tryptase can rise, can activate the mast cells, and then skin testing by the different components of the product, the medication, the vaccine, will give us the answer at which one has to be avoided or which one is the culprit. Next slide, please. And I wanted to draw you the attention for something that is critically important as we learn more. So in 2016, Dr. Lyons and Miller at the NIH, in association with us and other collaborators, diagnosed a new genetic trait that's called Ereditari alpha-tryptosemia. It happens so that the tryptase, which is, as I mentioned, one of the critical components of the mast cells, is elevated in patients who have mast cell disorders such as mastocytosis. But they discovered that some patients that do not have mastocytosis have an enhanced tendency for having severe allergic events. And this is coming from the duplication or triplication in chromosome 16 of one of the tryptase genes. And so the triplication of the TSAB1 gene induces that some patients have more than 4 tryptase genes. We have 2 from mom, 2 from dad, alpha, beta, and in patients who have this triplication, this is 5, 6, or 7 genes, and that associates with higher tryptase baseline levels. And the importance of that you see in the right side is there is a pedigree. And so we see families, and here you have 4 pedigrees where the children, you know, in the first one at the bottom, 1 daughter and 2 boys have it. And in the next generation, both mom and dad have it. And then in the third generation of the grandparents, 2 grandparents had it. And so you see in the upper part of it is that 2 girls have it, mom has it, and grandmother has it. So again, this was a critical importance because the screen a general population, this genetic trait, which is not a disease, it's a trait, is present in 4 to 6% of the general population. Next slide, please. And because of that, this is the inheritable risk for developing severe anaphylaxis. And that association, anybody who has this hereditary alpha-tryptosemia is more prone in the general population to present anaphylactic reactions. And we have seen that in patients who have a mastocytosis, but also patients who have presented anaphylaxis for no clear causes and for also reacting to bees and stings and other drugs and medications and foods. So essentially, we are thinking that this potential trait could be exacerbated by at the time of vaccination, and we are under investigating this potential risk factor. Next slide, please. So then I want to go back to granularity in terms of what do we know about the reactions that have occurred with the vaccines, the mRNA vaccines. So far, we have been able to analyze, you know, the Pfizer-BioNTech vaccine, and what we see here in the panel is that 90% of the people who have reacted to those the Pfizer-BioNTech have been females, and they have been able to be rescued with 1 or 2 epinephrine injections, and a majority of them, and we will review that in a second, have had a prior allergic reactions and or anaphylaxis. Next slide. And the summary of the slide before is that when the reactions occur, they occur within 13 minutes. Again, very rare, more than that. Here we have one patient who had 150, so more than 2 hours, but again, extremely rare. The patient had a documented history of allergies or allergic reaction to food, insects, or medication. And the patients also, 33% of them had experienced anaphylactic reactions in the past. And as I was mentioning, the majority of the patients were females. And that was for the first analysis that we did for the Pfizer-BioNTech. Next slide, please. So we did also the same analysis for the Moderna vaccine. And in this case, again, we found that 100% of the patients who had actually reacted were females. And again, there was a strong signal for those females to have had some sort of allergy in the past and potentially a severe allergy. They were all also treated, and as you see here in the column in the right side before the last one, they were all the certainty of those were grade 1, meaning that all the patients presented this hypotensive event with either respiratory or cutaneous symptoms. And in addition to that, we were able to capture in some of those patients a tryptase elevation, indicating clearly that the mechanism of those reactions are truly mast cell driven and allergic in nature. Next slide, please. And so then we went on to analyzed in employees of the partner system here with my colleagues Kim Blumenthal, Paige Wigner, and all our collaborators, over 64,000 employees, and look at the hypersensitivity reactions that happen in those employees, and to look a little bit about the frequency. So allergic reactions that were reported in about 2.1% of those. And anaphylactic reactions were confirmed in 0.02%, and actually 94% of them were female, and 33% at least had anaphylactic history, and the reactions occurred with a mean of 17 minutes. Again, so that totally replicated the data that was acquired throughout the world for the vaccines. And this is not discriminating Pfizer or Moderna. This is like data that we put together for both vaccines. Next slide, please. And I will also want to dwell for a couple of seconds in reactions that have happened that are more like delayed reactions, more local reactions. And you see here that both vaccines that you have here have been able also to induce some local reactions that have been large, that have been painful, that have been redness, inflammation, and the inflammation of the swelling of the soft tissues. And those reactions, as you see here in the initial 12 patients that we surveyed, those reactions occur with the first dose, and those reactions were able actually to be less apparent in the second dose in the majority of them. And a lot of them you see for patient dose 2, for patient 1, for patient 4, for patient 8, there was no recurrence of those reactions. So initially there was also a scare that patients who had large local reactions that were severe with the first one would not be able to receive the second dose, but indeed that did not pan out. And next slide, please. The reason for that being that here you have the description of what happened to all the patients. And again, a majority of females also were found to be having that. The symptoms were also associated with some myalgias in general, so some muscle pain, some fever, and there was complete resolution of all those reactions. And in those, for the dose number 2, the patients were somehow pre-medicated with antihistamines, and those antihistamines in the majority actually prevented that second large local reaction. And there was no sequelae, long-term sequelae for those reactions. Next slide, please. And I think that you see here again what were the symptoms of that reaction, which were again we found that only one male in this, excuse me, 2 males in the series, but more than 90% were females. And the major symptoms were the redness, the itching, and the swelling that was resolved with the second reaction. And there was no worsening for the second reaction. Next slide, please. So in terms of, finalizing what I wanted to mention today, vaccine hypersensitivity and anaphylaxis is a rare event. And although it is higher than for other vaccines, which typically for any vaccines that we have known, any hepatitis, polio, any others, it would be 1 in a million. This is 10 times higher, 1 in 100,000, 1 in 200,000. There has been no fatalities up to now. We have surveyed due to those hypersensitivity and anaphylactic reactions, and certainly females are more affected. And epinephrine is actually the only treatment for those reactions, extremely effective, and most of the time one dose has been sufficient. Tryptase should be obtained for the reasons that I mentioned to you before, understanding the mechanism, provided you know the cellular culprits, and being able to do risk evaluation and risk stratification for what needs to be done next. Skin testing is available for patients who have reacted to medications that did contain similar components, and there is actually no contraindication for patients to be vaccinated with all those caveats. And we have vaccinated already in the lower part patients with mastocytosis and mast cell activation syndromes, and they have been extremely safe. And the large local reactions that I mentioned to you have not recurred in the majority. Next slide, please. So my summary is that we have to pay attention to females, and in the same way that for other thrombotic events with what has happened, you know, with other vaccines such as you know, the AstraZeneca and the Janssen vaccines, for hypersensitivity reactions, critically females are more affected. Anaphylaxis again is rare, and there is no contraindication. Next slide, please. So the unmet needs that we have is we have not been able to do skin testing with the vaccines. This is the FDA has not permitted yet that we use those vaccines for other than the use that they are permitted to use. And one of my areas of expertise is desensitization. So I've been asked many times, you know, if somebody reacted to the first time, can we desensitize? Certainly that is a possibility, but has not been done. And for people who have reacted to the polyethylene glycol and other components of other vaccines, and for example to chemotherapy, doxorubicin, paclitaxel, and others that contain polysorbates or polyethylene glycols, could we do something for those patients so that they could actually be using the mRNA vaccines? Now, having said that, you know, patients have choices now, and patients can actually choose from an mRNA vaccine to another a DNA or protein vaccine that is available and may not contain the components that they might be allergic. So our recommendations at at this moment is that to proceed to different vaccines and different choices, because we have the ability to do that. But again, in certain circumstances, we really need to identify what are the components, and that would be certainly very important in the future to identify those and to critically identify the population at risk, so to avoid those reactions. And next slide, I think that was my last slide. So we have started with the NIH, and I'm the principal investigator at the Brigham and Women's Hospital, and study at the NIH with the mRNA vaccines for people who are at high risk, people allergic to foods, to medications, to Vs that carry an EpiPen, that have mast cell activation disorders, to allow those patients to be vaccinated. And I think the next slide, please. So this is the site, and you can access that site if you're interested and have been having reactions. Patients are being able to be vaccinated through those clinical studies. There is, I believe now, close to 30 centers in the United States that are associated and affiliated with this NIH-led initiative to allow everybody to be vaccinated. And particularly what we are very interested is in high-risk populations, you know, African-American populations, Hispanic populations. Asian populations have been disproportionately hit with the infection. And in those populations, the very high-risk patients who might be allergic or have mast cell disorders, we are very interested in capturing them and allowing them to be vaccinated through our study. Thank you very much.
That was a fascinating talk, at least to me, even being a vaccine person and a primary doctor, I learned a lot today. So if I understand correctly, so the vaccine safety or the vaccine interaction with the human society, the two aspects. One is generalized, our body. human population, we have a tendency, because everyone genetic or development determinants are different. So that's universal. Hypersensitivity. The other part is unique for vaccines. Okay, so let's focus on the general part on our body, our human. So you mentioned people have a hypersensitivity, so on and so forth. First question, from the epidemiology point of view, for the last 3 to 6 months, do you see for people, they have a tendency to have a hypersensitivity response to anything, seafood or traditional vaccine? Do you see this is the same thing toward the newer SARS vaccine, or the percentage or frequency for those people are same when they get other vaccine? I guess this is the first question general public probably is very interested in knowing.
So a couple of, there is a really important question, and it has two answers. One is what we call side effects, and side effects are, when people have, local, not as severe as the ones that are presented to you, but some redness at the site of the vaccine, or when they have some chills and some fevers, some myalgias, and those are what we call the side effects. And those side effects seem to be somehow in the same kind of frequency that we have seen with other vaccines. So it is normal that our body starts to react to the foreign, protein, DNA, RNA, and start to have the immune system in function. So our lymph nodes need to start working, and then we have to produce cytokines. So this is a general response that is probably occurring in more than 20 to 30% of the population. And even myself, I had the Moderna vaccine. I was out of commission for 1 day, and I'm a very healthy person. So again, this can happen in the same proportion of other vaccines. I don't see a rise. I don't see a signal there. What I see a signal is in true hypersensitivity or allergic reactions. It is 10 times higher than in the regular vaccines that we have scanned or looked at in general. We have never seen that frequency, and that's the reason why we went to the NIH and asked them, can we actually study this? So the purpose of the NIH study is to vaccinate about 3,500 patients at least initially with high allergies or high history of allergies, and see what we can learn from those patients and how can we vaccinate them safely. So your answer, in essence, is yes, those new vaccines seem to have a little bit of a higher induction of hypersensitivity/allergic reactions.
Thank you for your clarification. That's very important, and that answered my question. So you do see higher frequency. So then the question, let's focus on the mRNA vaccine, okay, for the time being, as that's what you observe. We are not trying to point out at any particular manufacturer, because they're same, basically similar. So let's say group them together. What do you think the components? Let's scientifically, I'm a nucleic acid vaccine person. I know DNA, RNA very different. So the question, do you think is that the RNA component, even though they have modified, they become less sensitized, modified nucleic acid, that kind of thing, or you think it's from the lipid nanoparticle part? Which part you think may be more as the culprit?
Yeah, this is kind of the key question that we have been having. And as I was preparing for the talk, and I did not have the opportunity to introduce that, there was a JAMA clinical report this week that says that the patient who reacted with anaphylaxis, I think to the Moderna or the Pfizer vaccine, had a positive skin test to the polyethylene glycol. So essentially, trying to put together that the nanoparticles or the envelope of those are very similar for the RNA vaccines that we have, either Pfizer or Moderna. So although they are not exactly the same, the core component is nanoparticles made of polyethylene glycol. That is also in other components, like I mentioned, in doxorubicin and others. And that seems kind of to be where the signal might be. And so that's where we're looking at that. Now, this is a very very rare allergy, again, in people, and people are exposed day in, day out to polyethylene glycol in a lot of things, in foods, normal medications and laxatives. So it's not something that provides an allergy to a lot of people, but certainly that is where we are looking for. And that's the reason I'm asking, the FDA and the companies to provide some vaccine to be able to test people. So to do that skin testing and to unfold the components.
Yeah, so I certainly, from my limited study observation, I also have my concern about the nanoparticle part, because the components is more complicated. They are not just one component, it's multiple components. The raw material, the supplier sources varies, even among different mRNA vaccine manufacturers. So it is. In particular, you mentioned the PEG. Do you think PEG has been traditional as a source of allergy or hypersensitivity? Or in this case, because the purpose for mRNA vaccine is to use PEG as a critical component to break the cell membrane. So here, they are more violent, let's say, use that word, more dramatic, induce maybe cytokine, cell damage. So the response may be secondary rather than someone see the PEG, immediately induce your mastocytosis or other release cytokine. So what do you think? Of course, this may be too deep, too early question, but I'm just trying to probing your understand, since you are expert in this area.
Yes, and in my other life, I am an immunologist for patients with cancer who develop allergies to their cancer medications, and we desensitize them. And I have to say that I have seen quite a bit of polyethylene glycol-induced allergy also in the cancer medications. So by analogy, because I don't have hardcore data, I would say that it is possible. It is possible, and those reactions are immediate. The immediateness when the injection, the intramuscular injection occurs, there is really an immediate uptake of those nanoparticles in the muscle cells, in the blood vessels of those muscle cells. The muscle cells have tremendous amount of blood vessels, so the absorption is within seconds, and within seconds you have some circulation of those polyethylene glycol nanoparticles. So again, that is a possibility. The other possibility, as you were mentioning, is what about the content, the RNA? So the RNA can bind to TLR receptors on cells, and there are some receptors that seems to be a little bit of a kind of longer, a little bit more delayed potential of that. And then there is the soup. I'm not really sure that I know exactly what the soup of the Pfizer or the Moderna vaccines are. Are there like some other sugars, some other
Yes.
leftover enzymes that may not 100% purify? That could be potentially there. So I think we are in the early steps of understanding that, although, the front runner, as you say, is potentially, the nanoparticle. The front runner, as I said, I don't discard anybody else.
Yeah, very good. I fully agree. Fascinating. But just along that line, because clinically or from a vaccine administration, it's fascinating. You see the second dose, the reaction, or response, whole body aching or tiredness, even some maybe fever, are stronger. Or I don't have the data, but it seems that's generally people accept the feeling. If that's the case, from an immunology point of view, usually we say that's more like a boost or memory or recall. Do you think that's some element there? If it's only the material direct toxicity, then every time should be same. But if the first time was milder, the second time will be stronger. So is there an immunology controlled mechanism as some memory? And the second part is actually more important. If someday we have to give a third dose, as saying the variant come out in 1 year later, would more people subject to this kind of memory or recall things? I know this is purely speculative, but I want to hear your opinion.
Yes, thank you. That's again great question, and important one. So in terms of the immune response that occurs with the second dose, like you said, we have awakened a dormant immune system. The immune system actually needs about 10 days to make an IgM, and then 15 days to make an IgG, and then all those T cells also have actually been awakened. So about 3 weeks or 4 weeks after the first initial reaction, when we receive the second one, there is definitely all the machinery, all the machinery ready to fire. And again, it's very clearly demonstrated that the second doses have actually had an increase in terms of, the chills, the fever, the myalgia. And I can speak for myself, the first one was kind of very mild. The second one, as I was mentioning, was I was out of commission for 24 hours. So again, there is definitely, and it's like a healthy approach, because that means that our immune system is actually working. The immune system took notice of what was happening, and it's good actually that we're producing, such a great, cytokine, chemokine, engagement of the immune system. So I do find that second dose, yes, it induces, a potential, more. And then when we receive the third dose, if it happens, within 9 to 10 months or 12 months, the immune system will already started to be a little bit more dormant. So I don't expect that third dose to be more severe. I would expect that more to be like the first dose, or a little bit just over that in terms of the side effects. In terms of the hypersensitivity is different. Because if we truly find that somebody is allergic to a component of the vaccine, by the second dose, that component is already, we have more IgE, we have more engagement, and that's our reluctance. As I presented to you, the first initial patient with the Moderna vaccine, I have not vaccinated the patient yet for the second dose, because potentially he could have anaphylactic. So allergy is completely different than side effects. And for the allergy, we're still working on identifying the components, what exactly is, we need to do that skin testing with the vaccines, and we need to identify what are the components, and can we actually desensitize those patients, because that's a question that has resurfaced many times.
Yeah, I think definitely that's interesting. We have to look. We don't know whether we will need additional dosage for mRNA-based vaccine. So at that time, we'll see whether it's true, as you hypothesize, maybe the immediate body immune response will subside, and then we can see. But on the other hand, I do have a reservation on the idea whether immune response or body response has to be good, because from a vaccine point of view, you have an adjuvant type of response, you have an antigen-specific response. If the adjuvant type or non-specific, they don't help immune response memory, then maybe not necessary, or maybe only bad. So we don't know. But anyway, that's good. So, but let's move on to another one. Since we know besides the body, reaction that may be universal, but the vaccine-based response may be difficult. I know your expertise or your paper has a focus on the mRNA vaccines. I wonder whether you want to comment, or you feel comfortable or experience a little bit on the recent information about adeno-based blood clot, even though the blood clot from different products, they seem to present different type, different mechanisms. So do you have any general comment on the adeno-related vaccine safety issues?
Yeah, we actually sent a letter to the New England, which was not accepted, about an opinion on this.
You can say here, we accept you here.
Well, I have been extremely interested because, again, the target have been more females, which are more prone to autoimmune phenomenon. And the fact that the patients who developed those reactions had antibodies against platelets, which and against heparin, which they had not seen before. None of the patients. So the kind of working hypothesis is that the vaccine has actually induced a very profound autoimmune response, at the level of the blood vessels, some components of the blood vessels, that has actually activated this pro-thrombotic activity. And that has been seen more, like I said, in females who are more prone to pro-thrombotic events. And whether the fact that those females are still cyclating with progesterone, estrogen, and some of them on birth control has been an additional critical factor that I think it needs to be kind of further studied. But we think that this is something critically important to understand, that although it's extremely rare, we need to understand why those females and where that age range do have this autoimmunity. what is of great interest is the autoimmunity part. You know, what are the elements, what are the antigens, you know, that are actually seen that then develop in this pro-thrombotic activity, and again, heparin is not indicated in those cases. But yes, I don't think it's an allergic phenomenon per se. I think it's an autoimmune phenomenon per se, which is probably at the basis of that, with the CD4 cells, you know, being activated, and some other cells engaged.
Yeah, thank you. I think that you answered actually the additional question from audience. They ask about, you know, the platelet-related complex, autoimmune response, and also gender preference, because it's quite striking in those incidents, universally, exclusively female. You know, that's raised both the mechanism question, also public health policy. You know, right now we are not suggesting only certain gender can use that, but certainly will generate concern among women, you know, especially in the middle-aged women or younger, you know. So this is a question we need to study, maybe also reveal something in vaccinology we never understand, because older day the vaccine monitoring is more primitive. Now everything is so sophisticated, you know, we do that. So I think this has a profound impact to us, everyone working in the field of vaccine. So thank you, and I think that's probably we have to wrap up. But we really thank you for taking time. I know how busy you are, because you were really today, you had to find the people cover for your clinical work and come here to give us a talk. We hope we can keep in touch, whether from the ISV part and some other activity. We hope have more interaction. For the other audience, as we announced before, we will have the recording both from Dr. Castells' presentation and the early one. They are available at YouTube, okay? So, and we have saved the previous one, so people feel free to go to YouTube and type in International Society for Vaccines. You will find all our recordings. With that, I will close this session. Again, thank you, Mariana, and
thank you very much.
We appreciate your help. Now I will turn to the closing remark to Dr. Margaret Liu. She will give us the summary of today's session, Congress.
Thank you very much, Shan. I'd like to start by thanking all of our speakers today. This has really been a fascinating time to hear the updates and to be able to delve into some of the other issues that relate to the vaccine. So thank you to all of our speakers. Thank you as well to the audience. This was a very engaged audience, and you asked questions that helped us to uncover even more information and address some of the issues and the science behind the vaccine. So thank you for the audience members. I'd also like to extend a really deep thanks to Dr. Shan Liu, because he's performed so much of the work for organizing this fantastic series going over a year for all these vaccines. And with that, to thank as well the co-chair, Dr. Linda Klavinskas, and also to thank the team that's behind this, that you all haven't maybe seen as much of, but they've been incredibly important for making this run smoothly. So thank you for Ted Gibson, and also to Benjamin Huangfu, who's been running all of these virtual symposia. We've been able to reach our audience around the world, and we thank you for those of you who've had to get up very early or who have stayed up very late for participating, including many of the speakers as well from the different time zones. And so as you can see, we've really been an international series. We've had speakers from all around the world presenting their different vaccine candidates, and we've also had an audience from all around the world. And so that really underscores how the International Society for Vaccines really does strive to be a way that scientists working in vaccines from all around the world can help each other, and that we can advance our work. So we'd just like to, I'd like to show you the next slide, please, to illustrate some of the other activities that the International Society for Vaccines does. And so our fundamental focus is to increase scientific interchange between scientists from around the world. But we have some very specific activities as well that we focus on. And so we'd like to encourage you all who are here and to tell your colleagues to join the International Society for Vaccines. We have a specific focus on mentoring early career researchers, whether still in training or whether in the earlier stages of your careers. And so we have not only at our annual meetings do we have development symposia where you can interact with people, ask your questions about careers, but we even have a specific mentorship program. This is an opportunity by being involved in ISV to increase your visibility, which will then help your research by helping you engage and meet more scientists from around the world for in these ways of public engagement, as well as then for your collaborations. In addition, if you join, we will be providing, as usual, a reduced registration fee for our annual Congress, which will be happening this year. And you receive also our annual newsletter, which is a members-only newsletter and highlights many advances as well as opportunities. We would encourage you to join as well because we try to have as global representation as possible and as well as diverse representation in the fields of vaccine development and research for the officer and the board positions. Next slide, please. And then I'd just like to close by announcing as well, again, our Congress, which will occur September 13th through 15th. It will be virtual. And we have it arranged so that people will still be able to not only present and listen to the plenary talks, but also to present posters and to be able to interact with people, to ask questions about their posters and to present there. So please see isvcongress.org for details. And then I just want to emphasize again that we will be posting all the talks from today, and the earlier talks from the earlier virtual symposia are also presented on the YouTube channel. And you need to look for International Society for Vaccines when you search in YouTube. So don't just search for ISV, but search for International Society for Vaccines. So with that, we thank you again for being a fantastic audience with all of the many interesting questions. And again, I'd just like to thank my colleagues for all of their work organizing such a great series. Thank you very much, and we look forward to seeing you in September.